and welcome to this afternoon's CardioCore lecture series. Today's topic is the role of inflammation in cardiovascular disease, and it's a pleasure to be joined today by Dr. Brittany Weber. She is an assistant professor in the Department of Internal Medicine at UT Southwestern's Medical Center. She specializes in cardiorheumatology and cardiodermatology, with a particular focus on immune-mediated inflammatory disorders and recurrent idiopathic pericarditis. Dr. Weber has delivered numerous invited presentations nationally and internationally and has published more than 100 academic articles related to her areas of expertise. In 2025, she received the Douglas P. Zipes Distinguished Young Scientist Award from the American College of Cardiology. Let's welcome Dr. Brittany Weber.
Hello, everyone, and welcome to the CardioCore Foundational Lectures in Cardiovascular Disease Prevention. I am very excited today to be talking to you about the role of inflammation in cardiovascular disease. So I've got a lot to cover, so I'm going to get right in. Here are my disclosures, including my grant funding. And so to begin, as a cardiologist that's been interested in inflammation since I was a teenager, everything has truly changed. Here I'm going to be showing you some of the key milestones of anti-inflammatory therapy in ASCVD. First, we have the fundamental proof of principle concept study that was published in 2017 with the canakinumab CANTO study. This was the first study that demonstrated that a pure anti-inflammatory therapy that blocks IL-1 beta led to a 15% reduction in cardiovascular risk reduction among patients with established coronary disease. Then in 2020, we had the colchicine-Ledoco-2 study that was published that demonstrated a 31% reduction among patients that were treated with colchicine compared to a placebo among patients with stable coronary disease. And then I always say in 2023, it was an exciting year for me. And why is that? Because this was the first time in the United States that the FDA approved an anti-inflammatory therapy for the cardiovascular risk reduction, which was colchicine at 0.5 milligrams. So taking that as a background, so let's take a step back and think through, so how does inflammation fit into the process we're here discussing today with atherosclerosis or cardiovascular disease? Now, we think of the immune system as being critical in both the early phase and well beyond atherosclerotic development. Mechanistically, the immune system activation is involved in many levels of atherosclerosis development. Here, you still fundamentally need lipid exposure. So that's important to remember. You need lipids that are translocating through a damaged endothelium. And endothelial damage is a key early process, and one way that the endothelium can be damaged is through pro-inflammatory cytokines. There's a strong contribution of the immune system with T cell activation, of course, modified lipid uptake by macrophages into the intimal space, which accompanies the first stages of atherosclerotic development. And when we think about the progression of atherosclerosis, this can be viewed as failed inflammation resolution. So smooth muscle cells transform to a proliferative state. They migrate to the endothelial cell region and secrete collagen to give rise to the, quote, fibrous cap. Smooth muscle cells can also transform into macrophage-like cells that take up lipids to give rise to foam cells, and T and B cells also will enter into the lesion and interact with other cell types to promote or retard lesion development. So indeed, efficient clearance of apoptotic cells, termed efferocytosis, is an ancient process that has evolved to allow organ development, maintain homeostasis, prevent autoimmune disease, and resolve inflammatory insults. And this is one key process that's been demonstrated to be defective in atherosclerosis. So I'm going to begin by giving you an immunology primer and by telling you why I think a general cardiologist should be excited about cardioimmunology, which is the broader context of the field. But as a cardiorheumatologist, which is my main area that I practice in, I first want to describe a few key terms. I'm going to give you a few examples of cardiorheumatology. So first, when we think about autoimmunity. So patients have autoimmune disease. This really arises due to a breakdown in tolerance. So when all of our bodies are developing, our immune system learns how to not react against self. And it is defects in the tolerance that ultimately leads to different organ-specific or systemic autoimmunity. But more broadly speaking, when we think about the general patient we all see in practice, the immune cell responses will dictate the balance between inflammation and its resolution. So, how can we think about the players? Well, we have to think about who is there and what are they doing. So, what is their phenotype and what is their function? And as it turns out, these plaques, the atherosclerotic plaque, they are so much more than just the lipid-laden macrophages that we all learn about in medical school, but they have much more diversity of immune cells mixed in. I really love this paper, and I would encourage anybody that wants to learn more to read this paper because this shows you with single cell sequencing technology, you can actually identify all the unique populations within a certain tissue and clusters of cells. And this is a carotid atherosclerotic plaque. And what we can see here is that this is a very heterogeneous mixture of immune cells that's present with a whole variety of T cells, NK cells, and B cells. Neurophages, macrophages, and monocytes actually make up only a very small portion of this immune contribution. So I would argue to all of you that atherosclerosis is a highly inflammatory process. So that really brings me into the crosstalk between the different fields of medicine. And what I'm really going to be talking about to you today is this leftward axis, right? Which is cardioimmunology. So the fundamental role of understanding the role of inflammation in cardiovascular disease. But where I sit and breathe is I take care of patients that have systemic inflammatory disorders. And this is the field of cardiorheumatology. And so furthermore, when we look at patients that have diseases characterized with systemic inflammation, we know that their risk is higher. This was a landmark study that was published in Lancet in 2022 by Dr. Conrad and colleagues that looked at 22 million individuals in the United Kingdom and identified patients with autoimmune diseases, both organ-specific and generalized autoimmune diseases. And what they demonstrated was that all levels of autoimmune diseases, this increased the risk of atherosclerosis and poor outcomes. Furthermore, what you can also see in this paper is that the number of the autoimmune diseases matters. So patients that had 2 or 3 compared to 1 autoimmune disease had a much higher risk of cardiovascular outcomes compared to those with 1, highlighting this notion of systemic immune dysregulation and inflammation. Furthermore, there really is fueling the fire in the need for better risk prediction in patients with systemic inflammatory disorders. This was another important study that was published just a year ago in JACC by our Danish colleagues that demonstrated among a large registry of patients that were referred for coronary CT. They looked at 85,000 patients and they looked at 4,000 of them that had one of 18 different autoimmune diseases. And what they describe in this study is that patients with autoimmune diseases, they were just more likely to have atherosclerosis. So looking at a carotid, whether you looked at having any level of plaque or level of severe plaque, shown here by the calcium score greater than the 90th percentile. Furthermore, if you looked at outcomes and you compare them to age, gender, and risk factor match individuals, they had worse outcomes compared to patients without systemic autoimmune diseases. And importantly, this paper also demonstrated that the risk was lower among those with controlled cardio risk factors. So, and another important fact is that we have to treat what we can treat today among our patients with systemic inflammatory disorders. And you'll see this theme going through my talk today. And so digging deeper into the fundamental pathophysiology of atherosclerosis and the pathophysiology of a disease like rheumatoid arthritis, this is a disease I commonly study, what we're beginning to learn is that there's shared pathways. And this is a labor of love of a review I did with Dr. Liao, where we really try to say, what is the pathogenic process of rheumatoid arthritis, and that's the joint. And so we're showing that here. And we say, what is the pathogenic process of the atherosclerosis involved at the endothelial level? And we say, where's the convergence? So what I'm not showing you here is the 100 molecules that we all learn in medical school and immunology that can make a lot of our head spin, but I'm showing you the convergence. So where do we see similarities in the pathways converge? And what we argue in this study is that we see this convergence along this pathway along the IL-1 to IL-6 pathway. And importantly, rheumatologists have been treating this pathway for decades, and we have FDA-approved agents that are treating these systemic inflammatory disorders along this pathway. So, what about another immune-mediated inflammatory disease and its inflammatory contribution to the process? And I want to highlight one specific disease, psoriasis. And so, in psoriasis, a genetic predisposition combined with environmental stimuli generates a cascade of cytokines leading to dendritic cell activation. And furthermore, we get cytokine production, such as from TNF-alpha, that will drive T cell differentiation into such cells such as Th17 cells. These T cells will then feed back further to cause keratinocyte, so proliferation, which also generates more cytokines, shown here. And you'll notice here that many of these cytokines that are being produced in the psoriasis lesion, such as TNF-alpha, IL-1 beta, IL-6, the S100s, they're not just pathogenic in psoriasis, but they're also known to be important in atherosclerosis. And as a disease model, there's been multiple studies in psoriasis showing the enhanced cardiovascular risk. And this is a study just compared to a control patient of the inflammatory component using FDG PET imaging here in psoriasis, showing all the different activation across multiple different organ systems, including the vasculature in a psoriasis patient. And we continue to learn from the field of rheumatology. This was a beautiful study that I would recommend anybody to read if you want to learn more, done by my UK colleagues, Dr. Books, that really goes through the current understanding and the management of patients with systemic immune-mediated inflammatory disorders. And a couple important points I'd like to highlight from this study is that the proven immune targets of benefit in rheumatic, we call them IMID, so immune-mediated inflammatory diseases, it's really fast. But we're also learning that successful targets for cardiovascular disease in the general population are evolving and that there's shared pathways. And what I just alluded to on the last slide, and what we also are seeing in this article here, is that IL-6 is a key shared IMID CVD target. So where do we utilize IL-6 blockade most in rheumatology? Well, it's commonly utilized in our RA patients, and we also use it in large vessel vasculitis. So we have longer data on following these patients over time with these disease conditions. And so this is kind of going through the outline of where I'm hoping to take you through today. So what I hope you got from this beginning of my talk was that the kind of overview of inflammation and ASCVD and this intersection of immunology utilizing an area that I live and breathe in as cardiorheumatology. And now I'm going to move into how we think about measuring inflammation right now in clinical practice. So that's the role of the systemic biomarker CRP. And then I'm going to end by imagining the future of identifying and treating inflammation in ASCVD. So first, we need to think about the pathway. So again, I kind of already alluded to this pathway earlier, but I want to kind of walk you through the NLRP inflammasome and CVD and understanding the pathway and the targets. So at the top here, I'm showing you have microtubular polymerization, which is important early in this process, and this would be where something like colchicine would block. Then you have the NLRP inflammasome, and this is an intracellular sensor that detects a broad range of antigens, resulting in the formation and activation of this complex. And ultimately, you'll get the activation of this. This will lead to the production of IL-18, a pro-inflammatory cytokine, and IL-1 beta, shown here. And then that will produce IL-6, shown here, which is the pro-inflammatory cytokine that has been demonstrated to be associated with atherogenesis, plaque rupture, vascular stiffness, and endothelial dysfunction. And this ultimately will lead to what we can all measure as clinicians, CRP, C-reactive protein that's produced by the liver. And so let's go through a little bit more about C-reactive protein. So this is not a new biomarker. And so how does one measure it? Well, as already discussed, we know that this was first discovered a long time ago in the 1930s. It was actually discovered by Rockefeller University, and that's why it's termed fraction C. So named because it was the C polysaccharide component of the pneumococcal cell wall, for anybody that likes a little bit of history there. And then by the 1940s, it was determined as an acute phase reactant. And what we know is that this can rise greater than 1,000-fold in certain conditions, such as infections or stimuli. So we have to remember that this is also an acute phase reactant. We learned by the 1960s that it was synthesized in the liver. And other important things about when we're measuring this in practice is that it has minimal diurnal variation and it's not affected by food. But what we also importantly have to remember is that this is not causal in atherosclerosis. So this is a biomarker. And we've known this now for decades that across all levels of cardiovascular risk, shown here by Framingham risk score, across the study that was now done over 20 years ago, sorry, it's going to the right slide. Over 22 years ago is the right timing. Is that CRP does still have additive value in predicting the relative risk of an MI, even when you're taking into account the LDL cholesterol. And this has really been corroborated by both by primary prevention as well as secondary prevention. So this was a landmark study, the Jupiter study, that demonstrated the effectiveness of statin therapy and primary prevention when your LDL is low, but when you're recruiting a patient where their CRP is high. So this was the study that many of us know well here, and just showing the cardiovascular risk reduction we're getting by using statin therapies among high CRP participants. We also have important data that was just published by Dr. Ricker and colleagues in the New England Journal of Medicine. That's a really beautiful study that looked at the single combined measure of hsCRP, LDL, and lipoprotein A. And this looked at the predictive of incident cardiovascular disease over a 30-year period among young, healthy women when it was checked. And what you can see here is across the different quintiles, and you can look at the predictive value of CRP as you go up on the quintiles, and the single biomarker measurement 30 years prior that predicted incident CVD. So again, just showing the utility of using these three biomarkers in clinical practice. Moving forward, so we have primary prevention evidence. We also have evidence of secondary prevention that shows the role of measuring hsCRP. This is looking at a collaborative cohort analysis that combined high or at risk of atherosclerotic disease who are receiving contemporary statins. So this is a study that again looks at contemporary statin-treated patients and looked at the predictors of incident cardiovascular death. And this was utilizing the PROMINENT, the REDUCE IT, and the STRENGTH trial. And what you can see here is that among these patients that were receiving statins, inflammation assessed by CRP in this was a stronger predictor of the risk of future cardiovascular events, more than so as assessed by LDL, shown here. So nevertheless, on an epidemiological level, elevated CRP is associated with an increased risk of CVD, and that it's been championed as a biomarker of cardiovascular risk for now over multiple decades. So previously, we've stratified CRP by greater than 3, which is associated with an odds ratio of 1.8 for the risk of CVD. Now, a lot of our conventional trials that we've been discussing will utilize a threshold greater than 2 milligrams per liter, whereas the risk of CVD was approximately 50% higher. But when we think about what CRP levels mean, we can kind of use those general ranges, a kind of above 2 versus above 3 as thresholds we can use in clinical practice. And I also like to remind patients or providers when we're testing this that it is an acute phase reactant. So if you get a very high value, such as often we think of as a level of 10, that we should consider whether this is an acute phase response and remeasuring it, or whether it could be attributed to another systemic inflammatory disorder, like a value that would not be that uncommon in one of my patients with rheumatoid arthritis flaring. So you do need to be putting the CRP values you're getting when they're high into the clinical context. So where does this sit in the guidelines? So this is the recent updates from the 2024 ESC guidelines for the management of chronic coronary syndrome. And what you can see here is that hsCRP is a class 2A recommendation. So it should be considered in the diagnostic management of individuals with chronic coronary syndromes. So shown here. So just some recent updates of where it sits on guideline recommendations. And moving forward beyond CRP, so when we think about measuring, if you remember from that NLRP inflammasome, I told you that it activates IL-6, which has really become one of the key important cytokines, and then that will produce CRP. And we know that IL-6 levels themselves are powerful predictors of future cardiovascular events. Given the variances in the assays, and measuring this in clinical practice, this is not routinely being assessed. We have used it in some rheumatologic settings, but even that, we often don't routinely measure this. But this just shows you over 2 decades ago data that shows you the plasma concentrations of IL-6 and predicting future MI among apparently healthy men, shown here on the study on the left. And this has been corroborated on the right by multiple other trials and meta-analyses since that time. We also know of we also have learned there's an increasing understanding of the role of inflammation and heart failure with preserved ejection fraction, a really exciting area and avenue. And we know that increased IL-6 levels are also associated with a new onset of HFpEF. So this was a study on the left that demonstrated that IL-6 was strongly associated with the risk of developing new onset heart failure and HFpEF among a cohort of about 2,600 community dwelling participants without heart failure. So I'm showing you the levels here. And on the right here, you can see that IL-6 was significantly associated with the risk of developing new onset heart failure in another study, the PREVENT study that looks at about 961 patients. And again, showing you the curves here. And so with that, we've kind of walked you through a little bit of the primer of inflammation and ASCVD. We've talked now a little bit about what we can measure in clinical practice, both CRP and also where IL-6 sits into this. And now we're going to be moving into the last part, which is really imagining the future of identifying and treating inflammation in ASCVD. And so part of what I do as a cardiorheumatologist is I do a lot of work on imaging, and I'm very excited about the role of imaging in this field. And why is that? Is because we really have the expansion of cardiovascular imaging tools. And so I really feel like a kid in a candy store sometimes when I'm able to work up and evaluate or do research utilizing these imaging modalities. But because you can see here, we're much further beyond echocardiography and ETT. They have clear roles, but now we can utilize all these tools in our toolbox. I've done a lot of work on patients in the rheumatologic diseases with microvascular dysfunction, and this is just showing you a stress PET, the gold standard. And look how beautiful that microvasculature is of our heart. We can also do coronary CT, which we have really exciting metrics of atherosclerosis where we can now measure coronary inflammation burden. And don't worry, you are going to hear a little bit more about this. And we also can do cardiac MRI, which allows tissue characterization of the myocardium and has the ability to add stress component where we can get myocardial blood flow. This is actually one of my patients shown here with lupus pericarditis, so inflammation around the pericardium. If I had a couple hours, I could tell you all about those other disease conditions, but we've got to be focused here. So what other biomarkers can we think about by quantifying inflammation in clinical practice? Well, I would argue that we can use imaging and risk stratification. And this was a statement that I had the opportunity to do with Dr. Mukherjee. That was a scientific statement 2 years ago in systemic inflammatory diseases, where we really walk through the way we can use imaging in these patients to improve both diagnostic screening, detection, and serial monitoring of our diseases in these conditions, and really how we can integrate imaging. And so what I believe is that an evaluation and management approach that incorporates imaging will really be able to improve our clinical outcomes among these higher risk populations, as well as in some of our patients with general cardiovascular conditions, particularly when we're trying to assess inflammation. But we do need to remember that there is lack of guidelines, and then right now this really leads to variable risk assessment. So what are some of the imaging modalities to detect vascular inflammation? Well, we have a lot of imaging modalities. I showed you a few on that last slide earlier, but we also have ultrasound, which is no radiation. We've got CT, which I'm going to show you in the next method. Cardiac MRI that I already mentioned, and then PET CT. I mentioned microvascular dysfunction, but we can also have molecular imaging targets of inflammation. Of course, we have FDG as a nonspecific marker of inflammation, and then we have more exciting molecules that more specifically targeting the inflammatory processes of inflammation. And so one exciting biomarker that I do want to measure, that I do want to discuss with you, is measuring coronary inflammation between perivascular adipose tissue. So this is called PVAT, and the technology that has been developed from this has been coined the term fat attenuation index, and this is really just taking this fundamental biology to a radiotranscriptomics AI approach that to then develop a risk algorithm, which I'll describe in a second, but this really shows you where the biology is, right? Okay, so we think about our coronary endothelium, and we know we have fat cells that are adipocytes that line that. So those adipocytes, when they see cytokines, so say you've got high levels of IL-6 being secreted, those adipocytes shown here on the top, they swell. And so the swelling of those results in a change in the Hounsfield unit we can see as radiologists. And so that is fundamentally, that Hounsfield unit is one of the fundamental measurements, and this really has beautiful mechanistic data. So anybody that's more interested in this technology, please do read some of the beautiful mechanistic papers that describes all the background that leads to this methodology. But this has been taken all the way from the PVAT or PCAT, so paracorneal attenuation index, which is just what I described, into further risk modeling with fat attenuation index, which adds on layering of radiotranscriptomics. And one important study that was really a landmark in the field was the orphan cohort study that looked at inflammatory risk and cardiovascular events in patients with and without coronary artery disease. And so what this was is this was a multi-center longitudinal cohort that looked at 40,000 consecutive patients that were undergoing clinically CCTA in the 8 UK hospitals, and they were followed for MACE. What this paper is showing you here is the prognostic value of the fat attenuation index, which I just described, among about 3,000 consecutive patients from 2 hospitals with about a median follow-up of 3 years. And what they're showing you in their data here is the phi score in quartiles. So you can see here Q1 would be your baseline, and Q4 you can think of that as the most inflamed patients. And what you can observe here in their data was that the phi score in any coronary artery predicted cardiac mortality and MACE independently from cardiovascular risk factors and the present or the extent of CAD. And we can observe here that this was significant in both obstructive CAD as well as non-obstructive CAD. So this is a really exciting biomarker that we're going to continue to learn about with ongoing studies, but it is another useful tool we can be thinking about when we're assessing inflammation. And so going back to our outline here, what are the benefits of treating inflammation? So I hope I've convinced you that inflammation is important. So what would be the benefits of treating this? Well, first, what can we all do here today? Well, we are all prevention cardiologists, and I want to just emphasize that we have to remember that the key things, your diet, incorporating healthy exercise, and smoking cessation, these are all anti-inflammatory therapies. So they're number 1, 2, and 3, what we need to be discussing and advocating for our patients. So we cannot forget the fundamental importance of just doing the things we can modify and reducing inflammation shown here. What are the anticipated benefits of adding anti-inflammatory therapy following aggressive use of statin therapy? This was just another study that looked at the relative risk reduction across what you would anticipate getting from the clinical trials that looked at ezetimibe, PCSK9, and anti-inflammatory therapy. And what you can see here is the relative risk reduction and the benefit and the greater benefit we can get by targeting inflammation with these therapies in clinical practice and risk reduction. And this is really just summing you up, saying, where are we going now? So these are all the immunotherapies for the treatment of atherosclerosis that are showing here. So the green are ones that have shown benefit. We've got drugs that have not been shown benefit, shown here in the red, or potential benefit, shown here in the yellow, and reducing inflammation or cardiovascular events. These are currently in clinical trials, or they're being tested in clinical trials. We also have a lot of immunotherapies targeting inflammation at preclinical stages. So again, I love to think about all these different pathways, and you can see there's a lot of novel and interesting ways that people are testing, targeting both the innate immunity, shown here on the left, co-stimulation. So this is the interaction between the antigen presenting cell and the T cell shown here. So a lot of different ways you can block that co-stimulation right here. And then the adaptive immune response shown here on the right. So these are things that are targeting the B cell and the T cell responses. So the field has really just beginning, and we've got a lot of excitement moving ahead. And really, where is our roadmap for anti-cytokine therapies development? So remember, I showed you the NLRP inflammasome early on in my talk, and this is just showing you now where are all the clinical trials. So we already have described here that we've got proven benefit or efficacy from colchicine from the COLCOT and the LEDOCO trial. We also have a neutral result, and we have to remember that from clear synergy shown here in the red. We also have the proven efficacy, but not in clinical practice as a tool we're utilizing for this, of the CANTOS trial. And then we've got 3 clinical trials, which are ongoing, that are investigating the hypothesis that IL-6 inhibition will lead to cardiovascular risk reduction among chronic CAD, acute MI, as well as heart failure with preserved ejection fraction. This is with the ziltivekimab platform, and we're really eagerly awaiting the results of these trials. And so going back to where are we right now with recommending any anti-inflammatory therapy for guideline recommendations? Well, the ESC 2024 guideline recommendations for cardiovascular prevention among patients with chronic coronary syndromes did up the level of colchicine to a 2A recommendation now that it should be considered at 0.5 milligrams daily to reduce MI, stroke, and need for revascularization among patients with chronic coronary disease. And where do our United States guidelines sit? Where our 2023 chronic coronary syndrome guidelines do still have it as a 2B recommendation. So this is where we are at now. And this was hot off the press just a day ago. So opportune timing for this talk today is hot off the press. Colleagues Dr. George Mensa, Dr. Paul Ritker, and others just published consensus recommendation for screening biomarkers, lifestyles, and therapeutics for inflammation and cardiovascular risk reduction. And so really just highlighting this important paper, really this is just their table 1 consensus recommendations. And really this is going through a lot of the points we really hit in this talk today. So I hope that you really have some key takeaways. I hope you could take from my lecture the fundamental role of inflammation in ASCVD and the intersection of immunology. And I hope you can also appreciate the example I utilize with immune-mediated inflammatory disorders. Again, this is an important field of cardiorheumatology. I hope you learned a little bit about how we can right now test it in clinical practice and the role of the systemic biomarker and how we think about utilizing values we detect in clinical practice. And then what the future of identifying and treating inflammation ASCVD can be, including some of the ways imaging modalities are coming out, as well as the current lifestyle recommendations we do, and then some of the therapies that are being tested. And with that, I'm going to end here and thank all of you. Here is my email. You can please reach out for questions, and I'm looking forward to the live session following this. So thank you very much.
Dr. Weber, Brittany, I want to thank you for a phenomenal presentation. I certainly learned a lot. I know we have a lot of unanswered questions, and while we wait for some questions to come in, I certainly have some. And this feels like a relatively nascent field, even though you've dedicated a good portion of your career to it. As we have increased numbers of targets that are potentially for therapeutic agents developed or yet to be developed, do you think one target is preferred when we think about the NLRP3 inflammasome, IL-6, IL-1, and maybe many more? Do you think it's going to be different for different manifestations of cardiovascular disease? Where do you think we're going to be going from a targeted approach?
Yeah. Well, first, Dr. Gluckman, or Ty, it is just such an honor to be able to be here today to really talk about my passion. As I hope you guys could tell in this video, really been interested in immunology and inflammation since I can remember. And so it's an exciting time, but we still have a lot to learn. So I would just say that. I think your question's a really good one. I trained as a B cell biologist and a T cell biologist. So I think we really have to start to understand the specificity by which these drugs target. As you know, the body of literature has grown over many really decades now, and really over the last decade itself has just been kind of on skyrocket of all the things we're learning on this precise pathways of the immune system, where we are learning that it does seem to be the most direct link down to the IL-6 downstream of the NLRP inflammasome. Of course, we understand the data that hsCRP is a biomarker. It's not causal, but we have the data in IL-6. So I do think IL-6 is a very promising target, which is why I am excited it's being tested across a number of trials, including other, a few different monoclonal antibodies. Of course, for large-scale trials testing it, in ziltivekimab, but there are other trials too. So I think that is going to be something that I'm very excited to learn. The field of IL-1 and NLRP inflammasome still has a lot to learn there of whether there'll be unique instances where that may be more beneficial with an NLRP inflammasome because it would target more pathways directly. I think also, because I take care of patients with these disorders on a daily basis in my clinic, we also have to remember the risk and benefits of all these therapies. Our patients with cardiovascular disease have a lot of comorbidities. And although, rheumatologists have been taking care of patients with these drugs for decades, they are not without risk. So we're going to have to be weighing that over time. And that's really where I think we're going to need to really move into the field of precision to know who is going to get the most benefit and by which pathway, and then that balance as well. And I don't, whether it's the same for every individual, I wouldn't hypothesize it would be, but we'll have to take some time and some precision to get there.
Yeah, I love that. And maybe it's a good segue for me asking, we've seen a little bit of a bifurcation of some of the studies for those, for example, using colchicine that to a large degree treated a population defined by being at risk, having atherosclerotic cardiovascular disease. And it was more of an all-comer treatment. In contrast, we've seen with IL-1, with Cantos, with the ongoing Zeus trial, with IL-6 inhibitors, that it was an enrichment strategy, as it was for Jupiter, to find people who had elevated hsCRP levels to get into the trial. Do you think the future, as we think about targeted therapy, will be testing people for something like hsCRP, finding people who define a priori a higher risk group, and that's the group that we would target? Or is it going to be one level removed where we might be treating people in a less selective way, independent of their hsCRP level?
Yeah, it's a really good question. And I do not envision a scenario of the latter. I think that we certainly have to think about biologics. I think as cardiologists, we don't need to be scared of using them. I love to think about the immune system and targeting the immune system, but we also want to know who is most likely going to be benefit, because these all, as do every drug in cardiology, many drugs in cardiology do have risk and benefit. So I do envision a future where we will be picking based on precision patients who are most likely. Right now, one of our best biomarkers is hsCRP. That is one biomarker. It is the one that is most well validated. We know many of the studies, as you and many people in the audience know, and some of the slides were shown of Dr. Ridker's. But there's also maybe other pathways that we may be measuring. And also there are other ways to measure inflammation. So one thing I'm actually very excited about as well is combining with imaging when we're thinking about who to treat. There are more novel metrics that are being developed that are looking at coronary inflammation. In this talk today, I described the technology we're using, coronary CT, to not only understand the plaque burden, but also understand the inflammatory metric of the plaque burden. So perhaps we're adding that to our knowledge of understanding who we're going to be targeting these treatments for. So I do envision a scenario where we will be measuring to identify who we would be treating with these therapeutics.
Perfect. And maybe it's a good segue to say you can't treat what you don't measure. And admittedly, we're continuing to learn. But maybe for not only yourself, in people who don't have rheumatologic disorders, who are you measuring something like hsCRP on?
Yeah.
It might be everyone. And if it's not everyone, or what do you tell your colleagues who are not cardiorheumatologists and not focused on immunology, who they should be measuring it on, maybe reflecting on that hot off the press article that was put out recently in JACC?
Yeah, it's a great question. And you're right. CRP is a very nuanced biomarker in my specific area of cardiology as a cardiorheumatologist. It's not that we don't measure it. It's just we have to take it into context that many of these patients are on biological therapy. And we also utilize other disease-specific severity assessments. But I think for the general cardiovascular patient, because at the end of the day, I am a prevention cardiologist. So when I'll see my patients, I measure hsCRP generally kind of routinely when I'm checking their lipid biomarkers. So I'm checking their lipids. If they have not checked an LPA, I always check that too. And I tell them I'm going to measure a biomarker called CRP, and I tell them what that is. And I also, before I send it to them, I say, before I send this, I kind of describe a little bit about what it is, so they're not, shocked if they see a value come back in their Epic chart. And then I kind of ask them, have you had any colds, any kind of infection illnesses recently? Because when you're checking this routinely, you will certainly be getting many ones back that are kind of above that 10. I still remember a middle-aged person that came back with a very, very high CRP, and I gave her a phone call going over data, and she said, "Oh, I just got over this upper respiratory infection. I didn't tell you about it." And, we remeasured it, and then it was lower. So that's when I will measure it for the general population. And then, of course, one question people ask is, do you remeasure? I certainly do remeasure it, especially because I'm taking care of patients with inflammatory disorders. Many of the conditions I'm treating, I'm actually trying to target the inflammation for some things. And I think that we will certainly be looking to the field more over time to understand trajectories of inflammation and how that's impactful over time.
I love that. And actually, it made me think about, you highlighted nicely the 30-year data that Dr. Ridker and others had published. If I remember correctly, that was just a single measurement.
Right.
So in someone who has an hsCRP measured, it's not greater than 10. Do you remeasure? Under what circumstances do you remeasure? And I imagine in a world in the future where we may actually be making therapeutic decisions based upon someone who may have a level between hypothetically 2 and 10, maybe even greater than 10. And how do you make decisions? And what are the factors or considerations that might motivate you to remeasure if they're not greater than 10? Didn't tell you, oh, by the way, I did have a recent respiratory illness or infection, et cetera.
Great question. For instance, colchicine, we know, I know that the controversial data on the conflicting data sets of where colchicine may be more beneficial and may be less beneficial, but we certainly have the FDA recommendation and our guideline recommendation. And we do have scenarios where the data has really demonstrated a benefit. And in patients like that, it's not, these are not the acute MIs, obviously, from the recent results where I'd be adding these patients, but in the kind of chronic patient with like the Ledoco, where I've already maximized all the other cardiovascular risk factors and I have a very motivated patient. Those are scenarios where I have started colchicine and we have remeasured and we have seen it go down, because we know from data in the literature that it would go down. So that would be another scenario where I'd remeasure. But I also think it's not, obviously for drug targeting, we would be remeasuring, but also we would, in that slide deck, when I talk about what else can you do, we know a lot of lifestyle factors also lower inflammation. So a lot of the things that we are promoting, telling our patients every week in clinic, those can actually lower systemic inflammation. So diet, exercise, weight management. We already know data from the GLP-1, right? The semaglutide SELECT trial, that's, which I think is very fascinating, by the way, that SELECT led to a reduction in CRP. And those, I think, the data suggests that it's independent of obesity. Clearly, weight reduction can lower CRP, but there's also a direct effect of GLP-1 that I think is a whole area that we're going to learn about. So I think there's a lot of things we do as cardiologists where we would be wanting to remeasure to see if our lifestyle changes are also lowering systemic inflammation.
That's great. Really helpful. Maybe I'd pivot or build off of what you just asked. If memory serves me correct, in Jupiter, individuals that got their hsCRP less than 2 and even less than 1 had the best outcomes. In CANTOS, there was a post hoc analysis that highlighted that people who got their hsCRP down had more consolidation of the benefit. And if they didn't drop their hsCRP, the benefit was not as great. And I don't think even achieved statistical significance. Do you envision a world in not just biomarkers being used to define who does and doesn't get initiated on therapy, but it might also invite after initiating therapy, we're retesting, and maybe there are, for lack of a better word, people who are better responders versus lesser responders, and that might inform whether drug therapy is continued?
I love this question. And the answer to that is yes. In part of my work I'm doing as a cardiorheumatologist, for instance, I study psoriasis. And psoriasis is one of my main disease models. And I just want to give you a highlight of this study because I think it's very fascinating, where we did a mechanistic trial testing a pathway that blocks Th17 cells. Okay, I'm not going to make you all go to sleep in the audience, but I have to tell you about this story. And we were trying to assess whether it would improve vascular health. And the vascular endpoint was kind of neutral over a short time period. But there were a portion of the patients in our study that got clear benefit from psoriasis, meaning their skin plaques went away, which is, what we are looking for in a patient with psoriasis from the dermatologic standpoint. And there were patients that didn't respond to the drug. So they would see me in clinic and they had the same plaques on their body. And we did, what I was very interested in is doing more precision, so doing immunophenotyping. So I took those cells for single cell RNA sequencing. And what we have learned, and we just submitted these results for publication, so they're still they're not published yet. But what we observed is the people who did not respond to the therapy, they were the patients that actually had a very homeostatic cell population in the blood, whereas the people who got the benefit had the kind of pathogenic Th17 cells, and that have been described in basic immunological literature, suggesting that this is not something we could have just found from seeing the patient in clinic or just a simple CRP test. It really took that precision to really be able to understand, at least in this one scenario of the study we were doing, where that actually could suggest that understanding more the precise immunophenotype could help us understand who responds best to therapy. So the scenario you just mentioned, it would be fascinating for more mechanistic studies where we really start to understand the people who don't respond, what is different about their immune system, and can that help us inform what therapies might be most effective in those patients?
Love it. Someone has asked about vitamins, supplements, their effect on HSCRP, from the standpoint of confounding the interpretation of results, and then B, do you encourage any of your patients to add supplements to a heart-healthy lifestyle to help reduce inflammation?
Yeah, it's a great question, and one that, and I certainly would love to hear your thoughts on this too. I think you kind of alluded to a lot of the challenges, right, with compounding and lots of things we need to think about as cardiologists. And these are the questions that patients come to my clinic with asking me. I had a patient actually just last week, just started my new clinic at UT Southwestern, and somebody was asking me about turmeric. And so what I really do is I avoid giving any specific recommendations on certain things. I really just encourage them. I give them the limitations of these studies, and then I really encourage them to really be eating a heart-healthy diet by getting all the essential vitamins and things that you would be getting from over the counter. Many of these we don't even we could go into the labeling of some of these things, but really just by getting it from just eating healthy. And I will kind of pivot my conversations to that, but I would love to hear kind of how you take this conversation in clinic.
No, I feel it's the exact same way. I feel like the evidence to help us inform those decisions is really challenging. I want to respect someone's desire to take where they believe it is helping their general health and well-being. I also take off the hat as the cardiologist and acknowledge that for individuals, I don't necessarily know the benefits or, for that matter, risks of some of these supplements across different conditions outside of cardiology. And so I feel like the strength of evidence is more modest in its benefit in reducing cardiovascular events. We've at least observed that in some of the large observational studies and randomized studies that have been done in looking at supplements. I don't know the data well enough from an inflammatory standpoint, but I share some of your opinions as well.
Yeah, and I think you also hit on an important point that I also discuss a lot with my patients too, is that although we think of supplements as they must be good for you, we can buy them at CVS, that we don't know, just like you said, and taking these in large quantities, right? Many of our patients are on multiple medications, and I'm often taking care of patients with multiple, or even different biologics together with some of the inflammatory conditions. And many of our patients will be on blood thinners, and many of these supplements in high doses can, interfere with the blood coagulation pathways. So I always kind of caution them, especially when people come to me with those labels of all the compounding, and you really don't know what's in a lot of these things, that we do have to exercise caution just because you can buy it over the counter or on the website.
Yeah, no, I agree completely. Sort of fast forwarding to where we are today, we have, if memory serves me correct, and you shared this from the ESC guidelines, a class 2A recommendation for colchicine. If memory serves me correct, class 2B, that was before I think we had the clear synergy results that came out as it relates to that. Do you see in your practice adoption of the therapy? And I guess I'm going to ask even the more challenging question is, we have a wide range of therapeutic targets. So imagine a patient with atherosclerotic cardiovascular disease, multimorbidity is more the norm than the exception, chronic kidney disease, obesity, type 2 diabetes, elevated LDL, enter in elevated LP little a. Where do you think absent somebody being treated with a drug like a GLP-1 receptor agonist, where are therapies like anti-inflammatory therapies going to fit? Is it a subset? How do you weigh those considerations of therapeutic targets?
Well, I think you're hitting on, like the big picture question we're all going to struggle with, right? Is one, I'm very excited for the next phase of studies to come out. I think they're going to be really important for us as cardiologists to understand across, chronic ASCVD to the acute setting to HFpEF, where kind of benefit we're getting from as these trial data come out. But I think that the next phase, assuming they have the benefit that we would be looking for to be utilizing clinical practice, that is the next question, right? It is like the clinical implementation of this and how we're using it in daily practice, recognizing, weighing all these things you just mentioned. I think we know we need to treat the factors you mentioned first. So these are the things that I'm going to be doing regardless, and I'm going to be aggressively doing. I'm not going to forget about somebody's high LDL just because I want to target their inflammation. I think that is equally important, and not in, the standards saying of Dr. Ritker that these are not in conflict, right? They are not. And I talk to my patients about both. I mean, people with inflammatory disorders, I'm treating their inflammation and I'm treating their lipids. As we're starting to think about all the therapies that you were just mentioning, lipoprotein A. Right now, we don't currently have drug targets we can utilize for our patients, but hopefully these are coming. And GLP-1, that is another really interesting question that we're going to have to continue to learn over time how this fits in, because I'm utilizing these very frequently in clinical practice, and I'd be curious to hear, your thoughts on that as well. But especially in my patients with the chronic inflammatory disorders, there's emerging data of benefit within RA and psoriasis, and many patients are eligible. And so I'm certainly utilizing this a lot in the cardiology clinic, and it does lower CRP. So how does one stagger therapies? How does one think about these therapies? And kind of implementation science is going to be the next, wave we're going to have to figure out.
Couldn't agree more. And I feel like, some of us have asked questions, what can't classes like GLP-1 receptor agonists and dual GLP-1 GIP, for that matter, SGLT2 inhibitors? These are drugs that cross multiple conditions. And at least from an arguable killing multiple birds with one stone, I hate the expression, but I use it all the time. It might be a way to be able to tackle this through multiple different mechanisms. And I think there is going to be a finite number of medications people take. There's a finite number of medications people can afford. So I think to the point of that, how do we enrich for that population most likely to benefit? Even coming back to some of the areas that you talked about, for example, with Lp(a), I think we're going to find that there are some people who have more moderate, some who have severe, and some who have very severe elevations. And so are we using it in everyone? Are we using it more selectively? I imagine that individuals who have the greatest amount of, I'm going to use the generic word, derangements or abnormalities, whether it be the magnitude of inflammation, the magnitude of elevation of other biomarkers, those are groups that I would at least envision have greater likelihood of wanting to put my thumb on the scale or my finger on the scale and try and encourage their use. So those are just some thoughts.
I agree. And, as we're starting, once we get to a scenario, I hope we're getting to a scenario where we're going to be able to be utilizing targets once we've, proven their benefit in clinic. We're going to combine the way we assess inflammation. And I know I'm always talking about imaging when I'm giving talks, but I've done a lot of work in imaging, and I do think that seeing is important too. So not only measuring systemic biomarkers, but also in combining imaging as a surrogate, so we can also really be making these decisions in the clinic, because these are going to be drugs with side effects that we have to be weighing in clinic. And we also have to be weighing the cost of these therapies as they're coming out. I mean, of course, there are things, the colchicine uptake has been very dismal, as we know, in terms of across cardiovascular conditions. But that is one very inexpensive and very easily accessible agent, but it's just not being very well used. And I do actually see a question just popping up, because I know where it's asking, actually, as I mentioned, colchicine, what would you measure if you're treating a patient with colchicine? So that was, we know from the studies on colchicine that it can lead to a reduction in CRP. Somewhere on the magnitude can vary depending on the clinical study and what you're seeing in clinical practice. But when your question, what biomarkers you'd be using, it would predominantly be CRP right now. It's not that other assays would not be relevant, but we're not to a point in clinical practice where you'd be measuring those. We talk about IL-6 a lot. And I take care of patients with RA where IL-6 is really integral to the pathogenesis. We treat these patients with tocilizumab. We don't measure IL-6 clinically because it's a challenging assay, and understanding the variabilities, the levels, what they mean, and also taking IL-6 across to kind of wild scale clinical use. We're just not to that point yet. So I do think right now our best biomarker is CRP, and then we have our imaging biomarkers, but I do expect that more will come as we begin to learn how things like proteomics and other kind of biomarker risk scores may be relative to or may be important for our patients as we're utilizing these more expensive therapeutics.
Two quick questions. I know we're at limited time left, but maybe one is, can you give a use case of where you're using imaging outside of cardiorheumatology that is informing inflammation imaging that's informing current practice, or are these purely research tools today?
Yeah, it's a really good question. So if you're talking about the kind of coronary CT and adding the metric of PCAT or Phi, the fat attenuation index is when you add in the radiotranscriptome and modeling to it. Those, I would say that the data is building, but they're not ones that I would be making management decisions in the clinic for. So those would be more where we've been doing a lot of research in this area. We've recently finished a study where we're looking at the use of the fat attenuation index in patients with systemic inflammatory disorders as prognostication. And then the big question is whether we can be utilizing these for therapeutic monitoring. I always like this food for thought case that I think about where I had a young patient who saw me in clinic who had a lot of family history of cardiovascular disease. This patient did have an inflammatory disorder, but was very stable. CRP was less than assay. And so to understand the cardiac risk, though, we did a coronary CT because his father had died very young of a heart attack. And because we were utilizing this research study, I did have a Phi score that was very high. It begs the question, but was I making a management decision today in clinic on that? Not yet, right? But really the recent data that is coming out, especially from the Lancet article and the ones that were presented at the ESC meeting, really are showing us really that we may get to a future where that will change, but that will take time. Other imaging biomarkers that I use as risk in clinic, it doesn't there's studies have used FDG PET, but that's not something we utilize in clinical practice. But another area I use to identify markers of risk in my patients is if they have symptoms that are suggestive of coronary microvascular dysfunction, I do evaluate for that. And we do know in both the general population and in patients with inflammatory disorders that is prognostic. It's not visualizing inflammation, but we know inflammation is an important risk factor for that entity.
Perfect. And maybe a last question. We know that immune modulatory therapies potentially increase the risk for infection. There's a reason that the immune system exists. Several of these future therapies might be injectable therapies. How do we overcome the concern as a cardiologist? I don't know how to address necessarily the issue or risks of infection. Obviously, partnering with a primary care clinician where appropriate in cardiorheumatology, partnering with your rheumatology colleagues. But is this the brave new world we're going to be used to? Or can you give, maybe in the last minute, any pearls about how to garner greater comfort with this? We're seeing this obviously in the case of recurrent pericarditis. I'm thinking about this from the future and presence of atherosclerotic cardiovascular disease management. Just any thoughts you have.
Yeah, I really love this question, and it's a great way. I could probably talk 10 minutes, longer than that on this topic. So I'll probably use the rest of our time if that's okay. But it's a really good one. So I treat a lot of recurrent pericarditis. We have an FDA-approved monoclonal antibody, rilonacept, that is approved for this. It's really changed the quality of life and the outcomes of our patients with recurrent pericarditis. So I have a lot of experience of utilizing a biologic that I'm prescribing as a cardiologist in the clinic, as do pericardial specialists. And so I think a lot of pearls, we can learn from that. And then the pearls we can learn from rheumatology. So this is really going to be where I do envision a field where there are going to be multidisciplinary collaborations to be addressing your question. A lot of education. And I do, of course, my passion, do hope the field of cardiorheumatology to grow, because I think this is an area where, this is a field where it's specialized on understanding all these different pathways, because not every pathway has the same targeted effects on the cardiovascular system. Some actually can worsen cardiovascular risk in terms of the biologics. And so I do envision that, but I do think some general guidance in the last minute is that we need patients and PCPs and other providers to understand the implications of being on these therapies, right? So that will be appropriate screening, letting them know that they should be alerting us if they have signs or symptoms of an infection, because we know these patients will have more severe infections, especially in the elderly. If you're immunocompromised, we know that varicella, UTIs, pneumonias, they can be a lot more severe when a patient's on an IL-X blocker, IL-1 or IL-6 blocker. And so we have to be understanding of that. And I think if we get to a scenario where we're going to be utilizing this in cardiology, we're going to have a lot of education. How do you screen for TB, right? You have to check for TB to start patients on these biologics. So I was in this discussion the other day and they were like, well, how do you do that? I was like, well, I check a T-spot. But, that's not something that cardiologist is doing every day and globally wise. So these are the efforts we're going to have to be thinking about as a community. So
I love this. Thank you for a really informative discussion. I know I learned a lot, our audience did as well, and really want to applaud you for the future that you're going to take us on in terms of learning more about this. Thanks so much for being a part of this presentation.
Thank you very much. And thank you ASPC for this effort. Okay. All right. Have a good day, everyone.